Good morning. I'm Marion Henry, Vice Chair of the Program Committee. Welcome to day 2. We hope you enjoyed the welcome reception last night and were able to reconnect with colleagues and friends. Just a reminder that we are recording and live streaming everything in this room, and the breakouts are also being recorded for on-demand access after the meeting. If you are a resident, student, or fellow, please stop by the reception for residents, students, and fellows tonight in the Magnolia Room. We'll have some invited faculty on hand who will talk about applying, interviewing, and research opportunities. Everyone is welcome. Don't forget to visit the exhibit hall. It's very important that we show our support to all of our wonderful sponsors and exhibitors. And you will see on the chairs and at the tables this morning this exhibitor passport. It has all of the exhibitors listed. And if you get 20 signatures on your passport, you can be entered into a raffle for a 3-night stay with breakfast at some point here at this hotel. So go visit the exhibitors, get the signatures, and then you have to turn this in by 4 p.m. Friday to be entered into the raffle. We have a packed agenda today, and we're going to jump right into our first session. As a reminder, the presentations, the abstracts are on the Whova app. You're welcome to ask a question in the question and answer feature, and our chat moderator will be able to ask your question, or you're welcome to come up to the mics for a brief question. The second plenary session represents some of our highest scoring abstracts, and it's my pleasure to introduce the moderators. Dr. Melissa Danko is an associate professor of pediatric surgery at Monroe Carroll Children's Hospital at Vanderbilt in Nashville, Tennessee. Dr. Kim Wallenstein is an assistant professor of surgery and trauma medical director at SUNY Upstate Medical University in Syracuse, New York. And Dr. Nicole Kuss is a surgical research fellow at the Children's Hospital of Philadelphia in Pennsylvania. Thank you.
Good morning. We're going to kick off the second plenary session with our first paper called Modeling the Relationships Between Political Partisanship, Medicaid Expansion, and Firearm Laws with Years of Potential Lives Lost from Guns Among U.S. Children, presented by Megan Paul.
Thank you to the Program Committee for giving us the opportunity to present this work. My name is Megan Paul, and I'm a rising fourth-year medical student at the Icahn School of Medicine at Mount Sinai. Thank you to my mentor on this project, Dr. Brian Coakley. We have nothing to disclose. Firearm-related violence has increasingly impacted the U.S. population with over 300,000 gun deaths in the last decade. Moreover, firearm-related injuries and deaths have significantly increased since 2010, as depicted in the graph to the right of the screen. 4.6 million children in the U.S. live in a home with a gun that is loaded and unlocked. The U.S. had 7,241 gun deaths in children in 2015, versus 685 in the 28 other high-income countries combined, despite those countries combined representing over twice the US population. Therefore, the aim of this study is to determine if political partisanship, 7 measures of gun regulations, and Medicaid expansion were related to years of potential life lost, or YPLL, from firearms among US children. First, the CDC's web-based injury statistics query and reporting system was used to determine the YPLL due to firearm-related violence in children by state between 2015 and 2020. The YPLL is often used as a proxy for premature death and is derived from the total number of years of life that people who die prematurely have not lived based on projected life expectancy. 7 firearm-related laws or restrictiveness measures and the status of Medicaid expansion were collected over the same time period, including assault weapon bans, child access prevention laws, firearm registration requirements, permit to purchase requirements, safe storage laws, the Giffords Law Center rankings, and the total number of firearm provisions by state. First, we use unadjusted linear regression to determine the association between each of the 9 measures in the YPLL of firearm-related death in children by state. Then we performed adjusted analyses controlling for poverty, educational attainment, poor mental health, and race by state from 2015 to 2020. An example plot of one of the unadjusted regressions is shown to demonstrate the methodology. Here, PVI in a given state is used as the exposure, with YPLL for firearm-related death in a given state as the outcome. In this case, higher PVI values represent Republican-leaning states, while lower PVI values represent Democratic-leaning states. However, the assignment of negative and positive values for PVI was arbitrary, and the reverse would not affect the results. Overall, we found that Alaska had the highest YPLL for firearm-related mortality in children over the time period of interest, whereas Rhode Island had the lowest YPLL. California, according to the Giffords Law Center, has the most restrictive gun laws in the nation, while Arkansas had the loosest gun laws. Idaho had the fewest firearm-related provisions, whereas California had the most over the time period. In the unadjusted analyses displayed to the left of the slide, 6 of 7 firearm restrictions, lower PVI, and Medicaid expansion were associated with lower YPLL in children. In other words, more Democratic-leaning states, states with tighter gun regulations, those with safe storage requirements, assault weapon bans, higher number of firearm provisions, Medicaid expansion, firearm registration, and permit to purchase requirements had lower years of potential life lost. In the adjusted analyses displayed to the right, after controlling for poverty, educational attainment, poor mental health, and race, displayed here, 6 of 9 of these factors were still associated with YPLL. These included more Democratic-leaning states, states with tighter gun regulations, states with assault weapon bans, states with higher number of total firearm provisions, firearm registration requirements, and permit to purchase requirements. To interpret these results, for example, states with a 1 percentage point increase in PBI, which represents 1% more of a state voting for a Republican candidate over the past 2 presidential elections, were associated with a statistically significant 4.10 unit increase in the years of potential life loss due to firearm-related deaths in children, given the positive beta value. While this may not seem like a large number intuitively, multiplying it by the statewide population of children can have a large impact on the years of potential life loss, though causality cannot be determined in this study. Ultimately, we see that Democratic states, those with more firearm restrictions, and those which have adopted Medicaid expansion, have lower YPLL in their pediatric population due to firearm-related death. Most of these relationships held true after adjusting for poverty, educational attainment, poor mental health, and race by state. Because YPLL is used as a proxy for premature death, we hope this can demonstrate the societal toll of firearm-related deaths among U.S. children. Future research should look into how individual firearm restrictions may reduce such premature deaths and potentially decrease gun violence. Ultimately, we believe that quantifying the YPLL of firearm-related deaths in children, and thus premature death, can serve as a better metric to demonstrate how gun deaths truly affect our pediatric population and hopefully encourage stakeholders to intervene in this ongoing public health issue. Thank you so much, and we'd like to acknowledge all the victims of gun violence and their families across the United States, including my own hometown community of Sandy Hook, Connecticut, and here are our references. Thank you so much for listening, and I'd be willing to answer any questions you may have.
Steve Fishman, Boston. First of all, congratulations on a spectacular presentation, being one of the less senior presenters on the podium. Great work, very poised. I have to say, and it's going to be a little unfair to ask you this question, this may be one of the most important talks of the decade to happen in our society. The fact that our children's lives have become politicized is a tragic state of affairs. We have so many conclusion slides that say future studies are required in our scientific sessions. It doesn't appear from your data that we need too many future studies to prove your point. I guess my question, which is almost unanswerable in its current politicized state, what can we do beyond this conference room as a group of surgeons, as a society, to have this incredible work have impact?
Yeah, so thank you so much for the kind words. And as our wonderful speaker yesterday alluded to in the keynote address, there are several things besides just appealing to policymakers. There are numerous advocacy groups. There are questions we can ask our patients and their families, especially those seen at high risk. Though I am a medical student, we're trained to ask, those pediatric patients or even women who are at risk of domestic violence for a social history and making sure that we intervene. So we as physicians can, in medical practice work for that, but also, outside in working with community organizations. But she also alluded to the fact that there is a lack of funding for data, and that is true. And the more funding that can be available for data to look into some of these causal associations, I think will really help to reveal some of the crux of the issue. Thank you.
Thank you.